think everybody liked it outside for lunch or something. Well, I think we'll get started here in just a minute. Just wanted to make a quick note, and I'll make another announcement about it in between lectures again. But the injection workshop, on the form it says that it's today, but it's not. It's tomorrow, Sunday, at 1 to 3. So not today, tomorrow. So if you're signed up for that injection workshop, it's Sunday, okay? Well, I think we'll get started because this is a very interesting topic that Dr. Jones is going to talk about today or this afternoon. So we'll welcome him back. He's going to talk about Charcot foot. And this is something that's very interesting. I didn't know a whole bunch about it until I started working at the VA. And then for a while there, I had every other patient was a Charcot foot patient. So I learned a lot pretty quickly, but he'll go over that and then osteomyelitis as well. So Dr. Jones.
Thanks, Sue. Yeah, she happened to get all the Charcot cases. And she was always she would come to me for, ask me about something. She's like, I got another Charcot case. So Sue could do this lecture for us. Okay, well, it looks like we're a little slimmer in here. That's probably my lecture ability, I don't know. That's okay, maybe people get back from lunch. So the initial ask was just lecturing about Charcot foot. And I've amended that, I've added to it, talking about osteomyelitis as well, and also the interplay between Charcot and osteomyelitis, as I feel like a lot of times they go hand in hand, and kind of that continuing conversation of the diabetic foot and what that means. So Charcot, anybody seen good Charcot cases come across? Okay, definitely out there, okay? So it's a progressive degenerative condition that affects one or more joints and is marked by bone fragmentation, swelling, redness, pain, and joint deformity, okay? Typically, it's going to be affecting that lower extremity. A little bit of fun history because, we always have to do this. Jean-Martin Charcot and his colleagues described the involvement of the foot in patients with tabes dorsalis, coining the term pied tabetuk. I don't know, I don't speak French, whatever that is in French, which has come to known as Charcot foot. Okay, so that was 1883. That's when it was kind of first identified, tabes dorsalis patients. First case reported in a diabetic patient was in 1936. So, 100 years ago, we're starting to notice this. Like we said with podiatry and ortho, there's classifications for everything, and there's several. And this is kind of the main one. It's called an Eichenholz classification, came out in the 60s. Basically, it's all based on radiographic changes within our Charcot foot. Okay, so stage 1 is osteopenia, that fragmentation, the joint subluxation, the joint dislocation. Okay, it's as things are, you have that red hot swollen limb, initial stage. Okay. Then it kind of cools down. You have the coalescent stage. You absorb the debris, and everything's kind of, not as acute anymore. And then in your third phase, that's the reconstruction phase, consolidation of the deformity, the joint arthrosis. Okay, you no longer have active stages, but the bones, are coming back together into their new form, which is usually not normal at all. When we talk about this, one of the things we're going to talk about is when we do surgery on these patients and when we don't, and it's very well accepted that you pretty much only do surgery in that third phase. You don't ever do it actively, so this is not something you're going to jump to surgery right away with. Okay, so when we talk about the causes of Charcot, there's kind of two predominant theories of what causes Charcot. There's a neurotraumatic theory, okay, just saying that there's joint destruction, fractures, or collapse of the foot that occurs as a result of cumulative mechanical trauma due to an insensate foot. And a lot of times we see in these patients where they do something super minor. Oh, I sprained my ankle, or I was just walking on the ground, or and then they come in with something on x-ray that doesn't look like they were just walking on the ground, right? But it's this small micro trauma, or it's usually not a big deal at all, okay? So that's kind of the neurotraumatic trauma. It's just these minor changes that over time with an abnormal foot cause issues. There's a neurovascular theory where this joint destruction occurs as the bone resorbs and the ligaments weaken as a result of the increased vascular reflex. Okay, so increased blood flow to the foot, you degrade the bone, and that's kind of the neurovascular theory. We don't know really which it is, and some people think it's kind of both. Okay, so then in 2005, people are like, well, we're going to really figure this out. Okay, we got these cool pathways, we got the rank L, we got this vicious cycle, we've got, you know, the pro-inflammatory effects, and they probably have a role in this, and let's get down to the nitty-gritty so we can really solve this, really fix this, really do whatever, okay? So they developed this new big cycle, okay? And there's tons of papers on it, okay? So we start looking at treatment options, and there's just like paper after paper of like trying to figure out like, is this rankle, are these inflammatory pathways, are they really actually doing anything? And what do they find out? Rankle doesn't do anything. It does cause monkey-bug sclerosis, which is the calcification of the vessels, but it has nothing to do with Charcot, okay? They're consistent more with neuropathy than Charcot, okay? Bisphosphonates aren't helpful in treatment. Parathyroid hormone is not active in acute Charcot. Prednisone, and you know, they don't aid in treatment. So we don't know what causes it, right? So I mean, this is what it comes down to. They did tons and tons of research, and they're like, we still don't know what it is. So there's all these theories out there, and there's maybe some contributing factors and pro-inflammatory, but we really don't know what causes it, which affects how we treat it as well, okay? We can't go in and give them a medication or something like that, and we don't know who gets it. We know why, you know, we can't guess who's going to get it and who's not going to get it. So we have no clue, okay? So now we get to treat something that we don't know what causes it, really. Kind of what we do know, though, is neuropathy, okay? Someone has to have neuropathy to develop Charcot. Just because you have neuropathy doesn't mean you're going to get Charcot. It's not like after 10 years you get Charcot because you've had neuropathy for so long. Nope, it's not the way it goes, right? Unfortunately. But this could be from diabetes. It could be from, you know, alcohol abuse. It could be from chemical agents. It could be from all sorts of different types of neuropathy. It doesn't just have to be our diabetic patients. They just have to have neuropathy, okay? Yeah, and like I said, I don't know. People just get really unlucky that get Charcot, and we don't know why. So, and thus it makes it harder to diagnose sometimes because there's not one factor that we know is going to cause it, okay? There's not one blood level that we know, oh, that's going to tip it off. So when we're seeing it, we're going to see this painless unilateral swelling, okay, on the lower limb. There's going to be erythema, there's going to be increased warmth, maybe crepitus or on passive range of motion, and it's going to be a progressive deformity as we look at it with radiographs. A lot of times we don't see an ulcer initially, okay? They just come in with a big, hot, red, swollen limb, okay? And there can be, you know, differing looks of this, okay? We see that one there where that right side is a lot more swollen, okay? A little bit more red. That's the affected side. The left side isn't, okay? Then they start to get this rocker bottom deformity. So the problem becomes, though, as we look at this differential, red, hot, swollen limb, as they come through the urgent care, or, you know, we see them initially, you're thinking, oh, it's just cellulitis, right? It's a diabetic, they have cellulitis, put them on some antibiotics, move on with our day. Or, you know, maybe it's an abscess. A lot of times these patients get antibiotics and get left and don't get a referral from the urgent care because it's just cellulitis. They don't get imaging, they don't get these other things, and so this diagnosis gets missed, and then it progresses. And so that's the biggest thing. And, you know, as I have medical students, I get a lot of third-year medical students with me doing their surgery rotation, and I'm like, just always, you know, there's these few things in podiatry that just constantly get missed all the time, right? Liz Frank fractures are one, and Charcot's another one, that they just get missed because people aren't thinking about them, and it doesn't seem to be a big problem. This patient will come in and will be like, you know, you ask them if they had an injury or trauma, and they're like, no, I didn't, you know, because sometimes just a minor trauma can cause that issue. So it's important to kind of have it in the back of your mind and to be like, okay, well, Charcot needs to be on my differential with these patients. You know, they have neuropathy, they, you know, have this red hot swollen limb, and so we need to be asking. And a lot of times that history is, I don't know, I might have twisted my ankle a little bit, or it hurt a little bit the other day, or like, usually there's not a good traumatic event, okay? So we need to get radiographs. Also, like we talked about for these serial radiographs, these baseline radiographs are so helpful as we see both to diagnose it initially and then to see it as it progresses, because this always progresses over time and it always gets worse. When we're also talking about dependent rubor, big helpful key, right? So we have this big, hot, swollen red limb. Put it up in the air, elevate it, okay? Elevate above their heart. And sometimes the literature shows up to 5 or 10 minutes, okay? Which is ridiculous. It's a long time to sit and hold a patient's leg for 10 minutes. You have 8 minutes with your patient. You don't have a full 10 minutes, right, to do everything. So, but just as you hold it up there, even after a minute or so, 30 seconds, you can start to see if that redness dissipates on elevation. That's not infection. Okay, that's not a cellulitic process. The cellulitis is going to stay beet red and hot if it's that more cellulitic. And so that dependent rubor is going to be more indicative of other things, which could be indicative of Charcot. Okay, doing these temperature exams, that limb is going to generally be several degrees warmer than the other sided limb. So just like taking an infrared thermometer, and that we all have, and just and checking that out. Okay. Ulcer exam, most of these patients, when they first have Charcot, their first Charcot event, don't have ulcers, okay? As they progress and as the deformity gets worse and as the bony deformities get worse, those cause the ulcers, but generally they don't have ulcers, okay? So here's an example of midfoot Charcot. It's actually a patient I just saw the other day that was coming in. He has had midfoot Charcot since the 90s, okay? So this is an advanced progressive stage. This is kind of what we're seeing. He's getting that rocker bottom foot right in the midfoot, okay? There's that consolidation of those joints. Okay, we're not seeing the joint spaces anymore. Midfoot Charcot is the most common place for Charcot, okay? That's generally what you're gonna see. You're gonna see that rocker bottom foot. You're gonna see where it collapses and then consolidates and kind of refuses into big massive bones and not have any joint spaces, and that's kind of what you see, okay? This is his other side, okay? So he has more rear foot Charcot, okay? He has a little bit of midfoot with more rear foot, but that whole ankle and subtalar joint, and it's just gone, right? I mean, where's the talus in there? Like, I can kind of see a body of it, but it's just gone, right? And so this is his other side as well. You see he's missing one toe. It's actually kind of amazing. This guy, he's had Charcot for 30 years now, and he's lost a tip of one toe and never really had ulcerations on the bottom of his feet. And it's because he takes care of himself really well and checks his feet and cares about his feet and stuff like that, even though he has massive bony destructive changes, okay? So, I mean, if you guys were to see this on an x-ray, I'm sure you guys would be like, hey, this is not normal, this is Charcot. Okay, these are easy pickouts, right? If we're getting the x-rays on these patients. Sometimes they're not all this simple to be able to identify and treat as well. Okay, so here's another patient. Anybody want to tell me what's wrong with this? I mean, we seen any changes on x-ray? Okay, so there is some Liz Frank injury right there, right? At that second metatarsal, base of the second metatarsal in that medial cuneiform, we see that on the lateral that it's like dorsally displaced a little bit, right? So they've got a Liz Frank injury. This is actually Charcot. This is actually first stage Charcot, okay? So yes, there's a Liz Frank injury, and a lot of times we see this types of displacement, dislocation in the midfoot of the Liz Frank joint, where, I mean, this patient comes in and doesn't have any trauma, right? Liz Frank injuries are usually acute, high energy trauma type things. This was, I don't know, right? My foot's hurting a little bit, but maybe I did some walking. They had no perception of anything traumatic happening, okay? So when we hear that history, a lot of times, if they're not high energy traumas, we're like, oh, we won't get x-rays or whatever. But if there's no history of trauma and we get this x-ray and then it shows this, okay, now we're thinking, well, neuropathic patient, more Charcot type thing, okay? So this was early on what they have happened. And then long term, this is what happened, okay? So now we get that weight-bearing image on that right side, and look how much dorsally displaced that midfoot is, right at the medial cuneiform navicular. Okay, so they're starting to get that rocker bottom foot, and seeing how it's on the image, the AP, there's starting to be that coalescence, starting to be that where it fragmented, all that bone is coming back in and healing and creating how that new foot is going to be. Okay, a lot of extra bony formation, and that's what ends up happening long term in that coalescence stage. Another one here. Okay, anything wrong with this necessarily? Say that again. Someone said something. Okay, pes planus. Okay, so maybe a typical pes planus patient, right? Okay, what about that? Yeah, there's definitely some calcifications in the plantar fascia. We also see a lot of excess bony formation right there at the first metatarsal medial cuneiform joint, right, dorsally and laterally. Okay, so this is actually a Charcot case where he's starting to flatten out and started to collapse right at that first metatarsal medial cuneiform, and then over time that coalescence occurred. Once again, showing it's tough to diagnose these on an initial X-ray, right? That yeah, he's got pes planus, he's got some other changes, but whatever. But this was another Charcot change. But getting those serial radiographs are very helpful to go back and start to look and to see that progression. Okay, this one's a little bit more obvious. This is more of that rear foot Charcot, okay, where our subtalar joint is completely obliterated. You're having that dislocation of the talus, as you see on that AP, okay? He's missing a toe. But that complete dislocation of that talus and starting to be that rear foot collapse, where the joints just dislocate, collapse, and then start to coalesce. So, okay. Here's another patient. This is interesting. This was normal radiograph. Okay, so this was, he had come in for something years ago and had radiographs, and so we had a baseline. Okay, and then he comes in with a little bit more red hot swollen. And what are we seeing there? We're seeing a collapse, right? Just like a pes planus. Like if I just saw that X-ray on its own, I'm like, oh, he's got pes planus, he's got flat feet, whatever. But in the comparison, it's pretty significant that, if in only about a year's time, he collapsed that much. Like that's not normal to see that much collapse on somebody who had a basically completely normal arch collapse that much in a year, okay? And then he keeps collapsing. So this one, we end up getting some MRI, and you can see changes of this MRI in that, okay? So where we see in that, I wish I could actually use my pointer on this, but that navicular, on the MRI on the bottom left, we see that navicular is darkened. We have that bone marrow edema going on. In the one on the right, we're starting to see those changes and inflammatory changes in the navicular, in the medial cuneiform, in the talus, okay? So we got this MRI because we're like, well, is this Charcot or is this something else going on? There's another slice. And when the MRI read came back, it just said, the radiologist read it as diffuse patchy bony marrow edema present within the distal tibia, talus, and calcaneus, which actually I would argue there's a lot more than that. There's in the medial cuneiform and navicular as well. This could relate to chronic stress reaction. Neuropathy could contribute to this appearance, okay? This is Charcot, okay? Those are the changes consistent with Charcot on MRI and on X-ray. And even our radiologist seeing that was like, there's some stress reaction, right? So, I love radiologists, but sometimes I don't. So that's why, I've got to be looking at that. I've got to be saying, hey, there's more going on than just he's got a stress fracture, right? He doesn't have a stress fracture in his medial cuneiform and his navicular and his talus and his tibia. I mean, this is way too much going on to just be he's got a stress fracture, right? With the collapse and everything, and that's indicative of Charcot as well. So it's not easy to diagnose. But there's a lot of clues along the way that we just have to kind of put together as well. But that's what we're seeing Charcot on MRI as well. And there's no definitive findings on MRI for Charcot. We generally don't do a lot of MRIs for Charcot. But sometimes in cases like this, it's helpful, okay? So I think this is what my patients see me as sometimes. Treatment options. Okay, we talked about total contact casting in the last segment, so I won't talk about it quite as much, but that is what we should be doing for these acute Charcot events, okay? If they're a red hot swollen joint, I had somebody come up to me in the break, asking like, couldn't we do just like those roller scooters or, offloading for these patients instead of a total contact cast, because that's easier and more doable. Yeah, and especially in these Charcot, if you suspect an initial Charcot attack, red hot swollen, it's not cellulitis, offload them. Just get them off that foot, okay? Ideally, it would be a total contact cast, but get them on that knee scooter. Get them on those crutches if they could do it. Half of those patients can't do that. Get them in a cast. Get them off that foot, because the worst thing you can do is continue to let them walk on that, and that's the problem with a lot of these. They go to an urgent care, they get antibiotics, you're fine, go home, and then it just gets worse. And then during that acute stage, it just continues to collapse. And then long term, they have a massive deformity because they weren't offloaded the moment the acute attack happened. So we just got to get them completely off of it, okay? Long term, we're going to be looking more conservative treatment. We have a crow boot. Anybody know what a crow boot is? Okay. You know what it stands for, Teresa? Okay, it stands for Charcot Restraint Orthotic Walker, okay? So they're the big black, I have some pictures of them, and then bracing, and then we have surgical options as well. The crow boots, I'll show you some, let's see. I'll show you pictures of the crows. And then the surgical treatment, I'll go through a little bit as well, just for your knowledge of what we do for these patients. Exostectomy, and then there's reconstruction, whether that's beaming, X-fix, IM rods, things like that, okay? So here's another why we use total contact casts, okay? This was a study done, and it was just showing association with offloading, okay? So these are patients that had on cast boots, okay? Whether it was a cast boot that was non-removable, like a total contact cast, or a cast boot that was removable, okay? And this was under the assumption that both of them were told to be non-weight bearing, and the duration of Charcot in months, okay, with that removable, was 10 months that they were in some sort of cast or boot, okay, when it was removable. When they were non-removable, like a total contact cast, it was 9 months, okay? So yeah, 1.5 months, but it's 1.5 months. But it was statistically significant in this study, showing that even if we're putting them in a boot, a cam boot, and saying stay off of it and giving them everything that they need, they're going to walk on it, right? Having it non-removable helps these patients. Once again, our total contact cast. Okay, so these are these crow boots. These are more long-term, okay? So after we get through the acute stage, they're getting these clamshell-like boots as well. It's kind of funny, my wife laughs at me sometimes because she says, we'll be at a store and I'll be like, oh, look, that patient right there, they've had an ankle fracture and they had it fixed because I can see their scar on their leg, right? I do that all the time and she thinks I'm weird. And then the other day we were in the store, I'm like, oh, that patient has Charcot. She's like, how do you tell? I'm like, look at that boot. Anyways, I notice people's feet. That's what I do. Yes, we have a question over here. No. These are custom made, very expensive, because like on the picture on that left, they are molded exactly to their foot, okay? So you can see how there's, when they coalesce and when they get this deformity and they get that rocker bottom or their rear foot's all weird, they have to make sure that it offloads them perfectly. So there's a lot of padding in them to make sure it molds exactly to their foot, okay? So they can be various different shapes. And then that way, the idea is to not put extra pressure on any abnormal portion of their foot, okay? And then put a lot of that pressure up through their ankle, like a total contact up through their leg, like a total contact cast. And ideally, these patients would be wearing this crow boot all the time. Like, when you're in Charcot, and that's what I try to tell patients right away when we're in Charcot, like, your life is different. you will never have a normal foot again. You're never going to have you don't get to wear normal shoe gear again. That's just not the option anymore, unless you want to lose your leg, right? Your life is going to change. And sometimes it ends up telling them that a lot of times, but a crow, a lot of times we put these patients in these crows instead of doing surgeries, instead of doing massive reconstruction surgery. And as I talk, you'll find out why, but they're in these crow boots, and it can keep them from ulcerating. It can keep them walking and ambulating. And yes, they're awful, and yes, they're heavy, and yes, they're not the sexiest thing in the world, but guess what? You get to keep your leg, right? And that's the conversation you have to have with these patients, and getting these crow boots. So as we start looking at exostectomies, surgical interventions, this is like the easy step, right? So they have this bump underneath in their midfoot, and they have this rocker bottom. So you just go in and you just like literally shave off that bone that's underneath there, right? So we just take a saw and shave it off. A lot of times they do better if it's on the medial side than on the lateral side of the foot, and we can do it with ulcerations, and a lot of times we do that to just get in there, get it off, get the pressure off, heal the wound before we would do a major reconstruction, okay? Because we don't like to do major reconstructions with wounds open. But then the problem is, we're always running into this problem of like, well, they have an open wound all the time that we can't heal because of their deformity, but we can't do surgery to fix their deformity until the wound heals, and like, it's an endless fight, right? So a lot of times these exostectomies can help. Pretty quick recovery, okay? We're just taking off extra bone, but it can destabilize everything. Once again, any surgery procedure we're not doing this till months down the road from their acute stage, right? Until they've coalesced, that they're stable. We've been watching them with x-rays. They're not progressing. They're not getting worse. We want to figure out what their end stage, like the demarcation idea, like wait until we know what deformity we're dealing with until we do something about it. And then there's always the decision of, do we actually do surgery or don't we do surgery? Do we just put them in a crow boot and let them continue to live their life without surgery? A lot of X-fix with reconstruction, okay? So these are kind of some pictures. There's these, there's actually like these, I guess you could call them smart X-fixes now, right? That you can actually like put in, and you can computer program in, and they'll like move over time, and they bring them into your office, and you type in your computer, and it moves the struts, and as you're trying to do this deformity correction, and I don't do this stuff. This is major university centers that are doing it all the time and stuff like that, but this is something that they do where they make the cuts, put them back, and then put their X-fix on and slowly change the deformities, because these feet are not normal at all. And the intention isn't to get them to have a normal foot. We just want them to have a plantigrade foot, okay? We just want to, if we can get a flat foot that doesn't have a big rocker bottom, we've won that game, okay? They're never going to still have it. So, a lot of these are these, and then you distract, and then you're, putting grafts in and stuff like that. So, these are big procedures, big X-fixes. Here's one. This is out of the East Coast where they do a lot of this. And, they took that foot on the left side and made it fairly normal, right? At least it's flat. At least it doesn't have a rocker bottom. At least there's not the valgus deformity. So, that's their ultimate goal with stuff like that. So, yes. Yes. So the question was, how long of treatment are we looking at? And yes, it's years. So and we'll talk about that a little bit more, but this is long-term because that X-fix that you've got on with that deformity correction, just having the X-fix on, you're looking at probably 3 to 6 months of deformity correction as we're slowly doing that, multiple surgeries as well. So the exostectomy is a much quicker procedure. These are massive reconstructions that you're doing, okay? So then you have IM rods. So here's one with, midfoot, rear foot, Charcot, and you end up putting in these big IM rods and just trying to stabilize the foot. And once again, just getting it to a flat plantigrade foot. These are a little bit easier in terms of the X-fix instead of the big deformity corrections. I do some of these IM rods. a little bit more minimally invasive because you just put the IM rod from the plantar aspect of the foot and put the other screws a little bit percutaneously so you don't have big, massive incisions. But you're just hoping that everything fuses when you do these. Beaming techniques. So early on, beaming technique has been around since 1997 when it was first kind of put out there. It used to be that people would try to do these, with the small screws, and this idea of beaming is kind of like a rebar type idea, okay? So we put these big, massive screws as big as we can get, right? So you're having 7.0 screws, you're getting like these massive screws that are taking up the entire cortex of your first metatarsals and your other metatarsals, and then just put 2 or 3 in them, and you just try to stabilize them. And a lot of times these cases are done. You put them in, you put them on an X-fix, and then you're just hoping that everything fuses, right? We try to realign and just put these massive, massive beams in, okay? And the idea is you put in as big a beam as that soft tissues and that bone can support. So you're just right on the precipice of blowing out the bones because you're putting as big of beam in, get as much mechanical stability as you can. And that's the idea of beaming. Beaming is probably done more for Charcot recons now than some of the other things, but it kind of depends. So here's some, you see on that second metatarsal, that beam through that second metatarsal is basically the same width as that second metatarsal, same with the fourth, okay? These are a ton of fun in surgery because you don't put this on power. Like if you're thinking a drill and you want to power it in, no, you get to hand crank these, and they're 120 centimeters long, and you're like, okay, 3 hours later, I'm done, right? Because you want to be able to feel it going in. You don't want to power it through, otherwise you just shatter everything and explode everything. So it's lots of fun. That's what you get to do as a resident. You get to, use a screwdriver for 10 minutes. But this is a beaming technique, and on that lateral you see that they're trying to get some sort of arch back. And prior to that, the problem with beaming is you're doing lots of big incisions because you're opening up every joint. You've got to take all the cartilage out of every abnormal joint. You've got to get rid of any of that extra coalescence. You've got to prep every joint that you're going to fuse. And so these are not only big screws, big incisions, big long surgeries, all sorts of issues with that. So here's another one, some pre-op imaging, both with that Charcot, that AP is really whited out, you probably can't see anything. And then just beaming techniques again, big screws. So anyways, let's talk about some literature though. Does anybody use literature for support, not illumination? I think we all do at some point, right? What in the literature proves that I'm doing the right thing? So anyways, but what does the literature say about these beaming techniques and everything else? Some of the literature, this is the literature showing. So recovery time is 1 year to fusion, okay? So normally when I fuse somebody's joints, no matter what it is, I can say, okay, well, bones heal 6 to 8 weeks, whatever, right? Maybe my big ankle fusions on patients, I say it's going to take up to 3 months to heal. In Charcot, you better plan on a year for these joints to fuse, okay? That is a crazy long time to tell somebody that, hey, guess what? You got to stay off your leg for a year, okay? It's been shown that there's increase of risk of amputations if you have any of these factors on your Charcot patient when you're doing surgery. Non-unions, new Charcot site, PAD, renal disease, post-op osteomyelitis, delayed soft tissue healing. So if you get any of those complications, you're headed down the road to amputation, okay? Even in, a lot of this literature that I'm gonna show comes out of these major, massive sites. There's, I don't know if anybody of you know Byron Hutchinson here in the Seattle area, podiatrist. He does tons of Charcot, right? He's you have a Charcot patient, you send it to him. He's, I think, getting ready to retire, but there's big sites on the East Coast. There's big sites, LA, all over the place that just do Charcot, that's what they do. They do these Charcot recons all the time. And this is where the research is coming out of, and with people that are doing them all the time. See, this was our picture earlier, right? This was a Charcot recon that had issues. So when we look at these surgical failure rates from the literature, just an exostectomy, 25% of these people are having additional surgery, okay? which I don't like doing surgery and then knowing in 1 in 4 of my patients are going to need additional surgery. When we talk about midfoot Charcot, you put those bolts in, so with our beaming technique, they will lose a half of their correction, 50% of their correction over a year, okay, that medial bolt. 33% need more surgery, and only 83% are resaving their legs after we do these Charcot recons. And these are people that specialize in this and do this all the time. Super constructs, so this is talking about beaming with X-Fix, 15% reulceration rate, 43% implant complications. So almost every 1 in 2, you're having complications with the hardware you put in. 66% need additional surgery, 80% limb salvage rate, and 90% of people are suffering a complication after these surgeries. So why do we do these? That's what we ask ourselves all the time. So yeah, these surgeries, you know, even Byron Hutchinson, who I worked with a little bit in residency, and he tells these patients, like, you have to prime them and get them ready for surgery. They have to have no ulcerations, you know, making sure that their nutritional status is as best as it can be, and their A1Cs are the best, and, you know, getting them all primed as much as you can before surgery. And then he says, I get 1 shot at this, and if it fails, you're losing your leg. Like, that's my deal going into it. And that's the truth about these patients. That you know, you can try to go fix things and do it, but in reality, like, there's a high rate of complication, a high rate of losing legs. And that's the way it is. And so that's why sometimes we say, that crow boot looks better and better, right? Can we keep them functional and stable and living their life in a crow boot instead of trying to be the hero, go reconstruct them, and ultimately have a 90% complication rate? So, you know, some of these people definitely need it, and some people do well with these surgeries, but there's just such a high complication rate, and that's unfortunately what it is, okay? Oh, here's this too. Ankle Charcot. So if you have rear foot ankle Charcot and you want to put a femoral head graft in because you've lost it and trying to get length back, and you put an IM rod in, 50% of that time that graft will incorporate, and 75% limb survival, okay? In the podiatry world, people said it's just, you know, a dead bone sandwich. You're trying to put a femoral head graft in and it just fails. So, okay? Yes? Okay, so the question was, does surgical intervention on these folks increase their mortality and morbidity rate? Yes and no. I don't know if there's any specific studies that, you know, evaluate non-surgery versus surgery and mortality rates. The problem is if we don't do surgery, they have an abnormal foot. And if they've had ulceration time and time again, and infection, it's leading to an amputation and death anyways. If we try to do Charcot, they're going to have a surgery, they're going to have complications, and which could possibly lead to limb and death. So I don't know if anything's specifically been studied one way or the other, but there's no good option either way. Yeah, and that's why it's looking at that patient. If they're willing to use a crow boot, those crow boots can be so helpful in keeping them from getting ulcerations, because that's really the end goal. If you have Charcot and you don't have an ulceration, you're going to be okay. Like my guy from earlier that I saw the other day that's had Charcot for 30 years and never had an ulceration on the plantar aspect of his rocker bottom foot. He's done what he needed to keep, you know, not having an ulceration. Yeah, he has to wear specialty shoes and some bracing and some stuff, but he's taking care of himself and he's doing okay. It's when you start that process of getting the ulcerations that it's bad either way. I think that's what it comes down to. So unfortunately, these patients, most of these patients that we're doing surgery on or Charcot, not all of them, like my guy, you know, but most of these patients have been living a life of non-compliance that have caused them to get to this place, okay? Non-compliance in medication treatment, you know, insulin or diabetes or not checking their feet or, you know, just like their life has been non-compliance. And you know, that's what we deal with on a regular, that's what you guys deal with on a regular, I'm just always trying to help these patients that don't seem to want to help themselves. And unfortunately, people change, But sometimes we have to go into these surgeries and these treatments assuming the people don't change. Like, if they've had wounds a lot and they're not offloading their wounds, and they're not staying off and they're not following directions for months and months, why am I going to do a massive surgery on them when I know they're not going to stay off their foot and it's just going to fall apart? Unfortunately, you just have to assume that sometimes. And I don't know if any of you guys are soccer fans and remember this from the 2006 World Cup when Zinedine ended up headbutting, and then France ended up losing the World Cup because of it to Italy. But when asked afterwards if he felt sorry or he wanted to, apologize, he said, "But to him I can't. I'd rather die." And sometimes that's the case. Sometimes we are, and we're not going to change. Let's look at a case study. This is one of the cases from our facility that we did a while back. So this guy came in. What changes are we seeing here on that left side? Anybody? Okay, rocker bottom foot. What did I see over here? Loss of arch, somebody said. Okay. What joint is dislocated? Yeah, the talar-navicular joint is dislocated right there, and also our calcaneal-cuboid joint is dislocated, okay? So the ones on the top right, that was his pre-normal foot, and then he comes in with something like this, okay? So he's dislocated. This is acute Charcot. We see this in a lot of patients, right? It's early stage dislocation of joints, right? So he goes on. We end up deciding that we want to do surgery on him, okay? He's coalesced. He actually didn't really like even long term, this is kind of the way he stayed. He just stayed in this dislocated state, okay? So we decide that we're gonna do a big reconstruction on him, okay? So it's hard to see, but he has an X-fix on them, and he also has beams on him, okay? So he has a big medial beam through the first metatarsal head all the way back into the talus, and then he has one in the third. So just two beams and then the X-fix. So the idea with the X-fix was to help support it so that in theory, he could put some weight down, but the X-fix would just help support everything so that we could fuse all the joints. So we were trying to fuse the talar-navicular joint, the navicular cuneiform joint, the cuneiform first metatarsal joint, okay, and then also some of the lateral column as well. So we go in, we prep all these joints, we spend hours in the OR, we put these beams in, we put this X-fix on, okay, and we're like, oh, that looks pretty good afterwards, right? We're like, okay, this is gonna be okay. He's going to have a stable foot, and he stays in the X-fix for 3 months, okay? So then you get to deal with pin care of these X-fix with these wires going in and not getting infection. And anyways, fun for the patient, fun for you. Dressing changes are, a ton of fun because those take 20 minutes just to undress and dress this thing, right? So then we get to, this is like at 6 months, okay? So looking okay. When we look at the lateral, he has a little bit of a high arch. We actually didn't want him that high, and we maybe put him in a little bit too much of a high position, okay? But everything's looking okay. Things are still in position, and we're like, okay, maybe we're good here, right? We're like 6 months out, fusions, doesn't look like things are fusing that great, but they probably are, right? We're like, yeah, he's probably doing okay, right? And then this starts happening, okay? So we were there, look at the arch height, okay. And then we're like, yeah, he's collapsing, okay. So remember how I said that half of the strength of a medial beam, the strength decreases by 50% over the first year? Yeah, that's what's happening. Our medial beam is collapsing, okay. It's now collapsed down through the talus, and even that lateral, see that location of that, it's the lateral beam, but it's the one underneath, and then it's collapsing as well. Like that whole foot is just collapsing, okay? And so I'm like, so we're like, well, maybe if I just put my head in the sand and not pay attention to this, he's going to be okay, right? How many, I don't know. As surgeons, we do that a lot. Well, maybe I just ignore this and it'll go away, right? Does that work? No, it never works. He came into clinic, And he's like, hey, is this normal? It was sticking out the back of his foot. We could see like 4 threads of screw sticking out the back of his foot. And we're like, no. Okay. So we're like, man, I got to get my head out of the sand and I got to do something about this, right? So, okay, so we have to go in and take the beam out. And then we're like, well, it'll probably still be okay, right? I'm getting some head shaking, right? We know this is gonna go, this is not gonna go well. Okay, and even this beam, and so then this, look from here, and then this other beam is starting to collapse out the bottom of his foot as well, okay? So we leave it for a while, and this is about 9 months out, and we're like, well, maybe we can keep it in, but ultimately, ultimately we have to take out that other beam as well. It doesn't pop out the back of his foot, but we do take it out as well, okay? So this is back where he's at now, okay? So this is where he started, and that's where he ended up. How did we do? We didn't do much, did we? Oh yeah, there's his post-op. There's a direct post-op, okay? So we fused some bones maybe, like that first metatarsal medial cuneiform navicular kind of look like they're fused, okay? The navicular, I'm like, I don't know, the navicular's gone at this point on that AP, right? It's just kind of a mess there. The plan was to do, he actually had bilateral Charcot, and the plan was to do bilateral Charcot on him. Yeah, we never made it past the one. But he's kind of fused, right? The guy's been in, this was a lot of years ago that this happened. He's in crow boots. He relatively minimal ulcerations. So overall, that's a good thing. He does kind of have a plantar grade foot. He doesn't have a rocker bottom foot, so maybe that's a win. But this is life with Charcot. Like, this is literally surgical treatment life with Charcot. It doesn't get better than this, unfortunately. Okay. We're going to move on to osteomyelitis. Any, pressing questions about Charcot right now before we move on? Yes? Okay, great.
They're walking around, and maybe they're an oddity, but is there something that we're supposed to be doing or monitoring, yearly x-rays or referring to specialists yearly?
Yeah, so the question is, having a chronic Charcot patient that's been through surgery that's seemingly doing okay, role in primary care, what do we do now, right? So the biggest thing with these patients is making sure they're getting foot exams on at least a 3-month basis, whether that's by you, by a podiatrist, by whatever, looking for any new wounds. They should be instructed that they should be looking at their foot for new wounds daily, whether that's a family member, whether that's them. They should be in something custom made, okay? Whether that's a crow boot, whether that's a custom shoe, they've got to be in something custom, okay? They never get to wear normal shoes again. Okay, they should be in something custom as well, and that may be a referral you make or a referral the surgeon or the podiatrist makes. And just always being aware that they know the signs and symptoms of acute Charcot attack, because a lot of times they have this chronic Charcot and they're stable now and they've had a surgery and whatever, but then they have an acute attack. And once that acute attack happens, we need to know right away, immobilize them, and make sure it doesn't get worse or they collapse more. So I guess those are the big, does that answer your question? Yes. So, and just they need to, minimum every 3 months, need to be seeing somebody that's doing a good foot exam on them. So, okay. And custom shoes or crow boots, depending on their situation. Okay, osteomyelitis. Oh, question over here. So when the question is who make custom shoes? We will generally refer it out to a prosthetics company, okay? There's several, Hanger, Thompson's, there's several, prosthetics companies that do that. You just refer them out to one of those and they build it. They generally do a really great job, whether that's building a crow boot, whether that's building a diabetic shoe, a specialized diabetic custom shoe with specialized inserts. That's the other thing I would say. It's kind of off topic a little bit, but when we talk about diabetic shoes, if a diabetic shoe doesn't have a custom insole, it's kind of worthless, okay? If we're getting diabetic shoes for our patients to protect their feet, they need to have a custom diabetic accommodative insole in them to help prevent ulcerations and wounds and calluses and stuff like that. So it can't just be an over-the-counter insole. So anyways, yes? So a lot of times so the question is, can you ask the prosthetics places to build a crow boot? Honestly, a lot of people just aren't getting the treatment they need. Usually the people that really need the crow boots are the people with those massive rocker bottom deformities, right? Or big ankle deformities or skew foot or something like, they have major deformity and they aren't a candidate for surgery, or they don't want surgery, or their podiatrist doesn't want to do surgery on them, Anyways, whatever that is. Those are the people that are really indicated for that crow boot. And yes, we should have that referral to that prosthetic company and say, hey, we need a custom crow boot for this patient, right? That they should be wearing all the time to keep them from getting ulcerations. If they're a Charcot patient that has minimal changes, they still have kind of a plantigrade foot, usually they can be tolerated in just a custom diabetic shoe with custom inserts. So, okay. But that could be something, primary care, that you're, sending out. Hey, go and have them make this crow boot. So, okay. Other questions? Okay, go until 2:30. Okay, osteomyelitis, okay? The quicker we diagnose osteomyelitis, the quicker we can treat and save limbs. Diabetic wounds can escalate quickly. Okay, and so then you read, actually had a medical student recently with us, and they were all into UpToDate, and they were like they actually kind of told us as physicians that like, oh, well, it says this on UpToDate, you should be doing it this way. That didn't go over well. Anyways, but you go to UpToDate, and gold standard is bone biopsy for osteomyelitis, right? So, okay, well, do we really need bone biopsy? Can we diagnose osteomyelitis differently? Is a bone biopsy necessary? When is it necessary? Okay, and just say that I'm talking about osteomyelitis of the foot and ankle, right? Osteomyelitis of the spine is going to be treated a lot differently than foot and ankle osteomyelitis. So just understand that it's different with what we're doing here. Osteomyelitis, I like to say it's a team sport, not an individual sport, okay? There's not one definite test that's going to say, I do this, it's osteo, okay? It's a lot of different things put together that we work together, different things that are coming together and saying, okay, this is how we're going to make the diagnosis of osteo. So that's how we have to think about osteomyelitis, okay? There's a history, there's lab testing, there's a visual exam, there's physical exam, and there's medical imaging. And we got to put all these things together, okay? Diabetes, okay, they're more likely to have wounds. How long has the wound been present? Okay, the longer the wound's been present, the higher the risk of bone infection. Goes back to my comment last lecture. If they say a week, it's been a month, okay? So take that what it is. You don't have to write that in your note. Patient says a week. I think it's a month. I think they're lying to me. Don't put that in your note. But just have that in the back of your mind, right? Infection, okay? What are we looking at? Has there been drainage, redness, swelling, fevers, stuff like that? Pain in an insensate foot is likely an indicator for osteomyelitis, okay? Normally they can't feel anything, right? They come in, I don't know, I had a wound, and then they come in one day and they're like, man, this toe that has a wound has been hurting me so much and it's been waking me up at night and it's painful all day long. Super big red flag for osteo, okay? Pain in an insensate foot is bad news, usually, okay? So be aware of that. And so sometimes we fall into like, oh, well, they can't feel anything. We're not even asking them if it's painful, but we should be, okay? WBCs, this is not a good predictor for diabetic foot osteo, okay? So we run it, we see if they're running a white count. Most diabetics don't mount an immune response, and so it comes back totally normal. And their white count is 8. Okay, great, whatever, right? Oh, they don't have infection, right? No, a lot of times they still can. And also, even if it's elevated, it can be non-specific, okay? So So then I like these ESR CRP, okay? So when my urgent care calls me and they say, oh, we think it's osteo like this guy the other day, I said, they got a white count, but they didn't. Sue was mouthing something over there. It's because they don't get ESR and CRP, right? Anyways, I always ask them, get an ESR, get a CRP for me, okay? I want a white count, an ESR, a CRP, okay, if it's suspected osteo. ESR, the higher the value, so there's been good studies about what our cutoff values are for these. The higher the value, the more likely osteo is present with an ESR. 60 or higher is indicative of osteo, and it's our best lab test to give us information about osteo, okay? CRP, this is fairly new research here that Lavery out of 2019. CRP was always kind of seen, like, even when I was in residency, it's like, well, we get it, but it's not super helpful. Now they're showing that a 7.9 or higher is a cutoff point for osteo, that higher than that is fairly indicative of osteo as well, okay? So as we combine those, if your ESR is less than 30, the likelihood of osteo is low. If it's greater than 60 and your CRP is greater than 7.9, high likelihood of osteo. ESR between 30 and 60, you're going to consider using imaging, okay? So labs, those ESR, CRPs are very good at helping us in this team sport, trying to figure out lots of different things, okay? Visual exam, megodactyly, okay? This is a patient, has osteo of that second toe. He has no open wounds. The nail's kind of weird. He doesn't actually have a nail on there. But like he literally came in with no open wounds. Had history of a wound a long time ago that had healed, but he had this big, weird, funky toe. It's osteo. That's very indicative of osteo. And it's more than just swelling of the toe. It looks different if you've seen it. It's just kind of this, and it's usually distal. It's usually the distal tuft. It's not like your sausage toe or swelling of a toe. It looks different, okay? And not necessarily any signs of infection or anything like that, but that's pretty indicative of osteo too when you see it. Probed bone test, okay? If we're able to see or probe bone through the wound, it is very highly indicative of osteomyelitis as well, okay? So we get that Q-tip and we push in. Is it a firm endpoint? Does it go all the way to bone? Is it a soft endpoint? Is it just the wound? Like the patient I saw the other day with a massive wound, I'm probing all in there, seeing if I can hit bone, and I couldn't. So, but any probed bone is highly indicative. There's been a lot of articles, and initially, sensitive and specific, they show that this is really limited to diabetic patients. It becomes very specific, but positive probed bone, 95 patients, 88 had osteo, 7 didn't. Negative probed bone, 60 patients, 57 had no osteomyelitis, 3 did, okay? So once again, pretty decent test, okay? If we can probe the bone, they probably have osteo, which makes sense, right? They have exposed bone to the air and this wound and whatever else is they're doing. Of course it makes sense that they're gonna have infection in that bone. So another good test. So we're starting to develop some of these tests, right? Our CRP, our ESR, our probed bone, is there pain in that area? Starting to get these things that are helping us go down that path of this is osteo. Radiographs, fairly specific, okay? If we're seeing those changes on radiographs, we can detect that bone destruction even without clinical signs of infection. We can eval for gas in the tissues, which is a surgical emergency. You see gas in the tissues, they better be getting surgery like that day in the next few hours, okay? Radiographs are cost-effective, easier to obtain, and this is also an important part of serial radiographs, okay? So 2 different numbers there, but early radiographs aren't going to show osteomyelitis. It takes 2 to 4 weeks for them to show up on radiograph, okay? So you got to have that in the back of your mind. Just because you're not seeing it doesn't mean it's necessarily there if it's early on. Also goes back to the history taking. How long has this wound been here? If the wound's really only been there a week or 2, they could have osteo and you don't see it on radiograph for several weeks later, okay? So radiographic findings, we're going to see these cortical erosions, we're going to see this fragmentation, we're going to see the destruction of bone, okay? So here's some positive arrow sign action going on here. Radiologists like doing that, so we can see what it is. But baseline radiographs are very helpful with this. And that's one thing, like when I see new diabetic patients in my clinic, I'm getting like even if they're a brand new patient, they're just coming in for a diabetic exam, no wounds, we're just establishing care, I'm gonna get a set of x-rays for them because more than likely, eventually down the road, I'm gonna want to go back and say, what's their normal bone structure look like so that I can look for those early subtle changes on their osteo changes when they get it, okay? So I like having those baseline x-rays to go back and compare to, because that's a lot of times how you're gonna see these is in a comparison, okay? When it gets bad enough, it's very obvious, but here's some more osteo, okay? That left-hand side there, all that fragmentation. Is that two? Anybody see where the osteo is in this? Say that again. Fifth metatarsal head there, right? It's like fractured and like, okay, so there's our osteo there. Obviously, this is not their first rodeo, okay? They've had some other issues. Okay, where's the osteo here? Okay, I hear PIP of the second, right? Yeah, the DIP, right? DIP, yep. Okay, so yeah, right in that distal phalanx of the second toe at its base, at the head of the intermediate phalanx, okay, we're starting to get that breakdown. We're starting to see that. So yeah, definite osteo right there, okay? So when you're seeing, like when I see this on x-ray, I'm like, they've got osteo. I don't need an MRI to tell me they've got osteo, right? Especially if I have a lot of other signs, okay? What are we seeing here? Megadactyly? Gas in the tissues is what I'm looking for. Gas in the tissues, right? So we remember this image that I showed earlier. I think it was over here, and it was in surgery, and the lady that we had opened up. This was her initial radiograph. Okay, we saw that gas in the tissue, and so that's why we went in, and she didn't want the amputation initially. This is what we were seeing. So that was open it up, clean it up, and then go do a TMA later, okay? So those radiographs can tell us a lot of things, but that gas in the tissue, surgical emergency, okay? Guys over here, see where it is? Yeah, so it's right between the first and second toe, right at like the head of the first and second metatarsal up to the hallux. So those little dark bubbles there, okay? So, okay, what about this? Where's the osteo? Second toe. Yeah, there's a little positive arrow sign there for you guys, but so you can actually see he's missing the distal phalanx, and then at the proximal interphalangeal joint, there's a dislocation there, and there's fragmentation of the bone, okay? So that's all pretty chronic osteo that's going on there, okay? There you go. Sometimes it's better to be a weasel. This was actually my we had senior quotes in high school that you put in the yearbook. This was actually mine. So that's where I was as a high schooler. Okay, moving on. MRIs, okay? They've been seen as a definite imaging for osteomyelitis, okay? So a lot of times we'll see, okay, well, they might have osteo, let's get x-rays, let's get an MRI, do we really need MRIs though, right? And because they get ordered a lot. They're expensive, and they may or may not help us, okay? So when do we need them and when do we not? Bone marrow edema versus true osteomyelitis can be challenging to determine, okay? And many times MRIs overestimate the places of infection, and many times they cause unnecessary amputation, okay? So I love my radiology colleagues, but as many times as I've read on a report can't rule out osteomyelitis, I'm like, well, thanks, that was helpful, right? But I see that all the time. But MRIs to me generally overestimate. So, somebody works them up and they get an x-ray and they get an MRI and they're saying, oh, this is so helpful, I'm gonna get all this imaging and then I'll refer them and send them to the surgeon. but then it shows that there's bone marrow edema, and I'll show you some pictures of like, all the way up the metatarsal shaft. So the radiologist reads it and says, okay, there's osteomyelitis all the way up the first metatarsal. And I get into surgery and I'm like, well, yeah, there's some in the head, but it doesn't extend all the way up into the first metatarsal. And so I just take out the head, but then the question is, well, why didn't, on radiology, the MRI said that there was osteo in the entire metatarsal, and why didn't you take out the entire metatarsal? And like, it just gets to be this like, and then there's medical legal issues, and right? So a lot of times if I know it's osteo, I don't get an MRI. Like, if I can see osteo from my probe to bone test and my x-ray, and like, I don't need an MRI. I know what I'm gonna do. I'm gonna cut that thing off, right? I don't need an MRI to confirm that for me, okay? There's some instances that MRIs are helpful. A lot of times that's more calcaneal osteomyelitis, or stuff that, we're a little bit more concerned, or they might be buying a BKA, or it's, we're not quite sure, but I don't get MRIs a ton for osteomyelitis, honestly. It's very rare, okay? CT, they're just not necessary for osteo. If you're gonna pick one, pick an MRI, don't pick a CT, okay? So there you go, there's what we see with changes. Does this look very similar to Charcot? It does. A lot of findings on MRI look pretty similar between Charcot and osteomyelitis, okay? But we're getting those changes. Here's a perfect example, okay? So there's changes on this MRI, both left and right, okay? Pretty much encompassing all of the talus and a lot of up into the tibia, right? Where it's lit up on that right side all the way, quite a ways up. That will get usually read by a radiologist as bone marrow edema and probable osteomyelitis all the way up there, okay? Do they have osteomyelitis in that entire talus and portions of the calcaneus and as much of that tibia? Most likely not, right? It's in the ankle joint, it's in the surrounding bone, but it doesn't extend all the way as high as that goes. So then it gets overread, and then, anyways, then there's issues. So, but I'm sure on X-ray you see signs of osteo before this MRI. So, but that's what MRI does, or osteo does look like on MRI. So on that left side, that darkened metatarsal in the middle there, I wish I could point. It's a good portion of that metatarsal. When we got in there, it didn't need that much as well. So, okay, wound cultures. Wound cultures. Who loves doing wound cultures? Urgent care loves doing wound cultures. Okay. Thing I think about wound cultures is they've got to be a deep culture, okay? Taking a swab and they have an open wound and they come into the urgent care or they come into primary care and they've got this wound there and you're like, oh, I'm gonna swab this, right? And you just and put it in a culture tube and send it off, okay? How many bugs are you gonna get? Like every bug out there, right? There's gonna be so many bugs because there's just gonna be all this extra normal flora and fauna and contaminated and stuff like that, that then, infectious disease calls you up and they're like, they're gonna die, they've got like 1 million bugs on them, right? Broad spectrum everything. And when in reality, it's like, probably not, okay? So if we're doing cultures, that's fine, and infectious disease loves cultures, but it's gotta be deep. You've gotta debride that wound, you've got, like I may do it in surgery, I amputate, I take everything bad out, and then I do a deep culture so I'm not getting contaminants, okay? You preferably before the patient gets on antibiotics so then you can see what it's sensitive to, but you don't wanna just superficial swab something in clinic as it comes out, okay? That's not gonna be helpful to anybody, okay? Bone biopsy. Okay, so we get back to the question of bone biopsy. Well, why can't we just do a bone biopsy right away, diagnose osteo, and move on? They can come back positive when there's no true histological evidence of osteomyelitis, okay? It has been regarded as a gold standard for determining osteo, so I get calls all the time from infectious disease. There's someone on the floor, they've got this wound, they're concerned about osteo. Can you get a bone biopsy for us, and then we'll treat them? And I'm like, well, depending on where it is, I'm like, well, why would I go take a bone biopsy of this toe, bring him back to the floor, start treating him for IV antibiotics for 6 weeks, when if they have osteo, I'm just taking the toe off and we're moving on with our life, right? Like, a lot of times a bone biopsy is just extra work and unnecessary, okay? So this was an interesting study recently as well. how reliable a bone biopsy is, okay? So they looked at 39 specimens. They had 4 pathologists look at these, and they said, was osteo there or not? And they could arrive at 1 or 3 possible potential diagnoses. No evidence of osteo, no definite findings, but can't rule it out, and findings consistent with osteomyelitis, okay? In a third of the cases, there was complete agreement between all 4 pathologists whether osteomyelitis was there. In 41%, clinically significant disagreement between pathologists, okay? So almost half the time, different pathologists are gonna look at this differently. So it's hard to say that something's a gold standard when half the time 2 different pathologists aren't gonna even agree whether there's osteo or not, okay? So just keep that in the back of your mind. Here's common bugs, what we're gonna be treating for when there is osteo. It's gonna be usually polymicrobial. So overall, there's not going to be a single test to tell us what we want to do with osteo, okay? It's a team sport. We're going to try different things, okay? We're going to talk to the patient. We're going to have the labs. We're going to have the medical findings. Big things for me, ESR CRP, okay? Those can tell me a lot. Probe to bone test can tell me a whole lot if they have that. X-rays, if there's findings positive on X-ray, that's going to tell me. Like, those are big things for me. I rarely, if ever, do bone biopsies. I rarely, if ever, do an MRI, okay? Because most of the stuff, I know whether it's osteo or not by the time I get all that other information, okay? So this looked at what's a definite diagnosis for osteo, what's a probable, okay? So this is saying, if we're seeing abscess or purulence or a bone sample with a positive culture and positive histology, it's definitely osteo. It's probable if, even if you get any 2 of those, right? So if you have visible cancellous bone in the ulcer, so probe to bone positive basically, and, bone sample, MRI, those are, definite osteo. And then you start getting into possible, okay, ESR greater than 70. But the way this article showed, though, is there's all these criteria, and the more findings you have, the higher it bumps it up. So if you have an ESR greater than 70 and the ulcer is older than 2 weeks, and your plain film radiographs show cortical erosions, then it bumps you up to definite osteo, right? When we get to the other end of it, unlikely, normal MRI, normal bone scan, no signs of inflammation, and normal plain film radiographs, and ulcer for less than 2 weeks, and superficial infection, okay? So in those patients that are it's brand new, there's some infection, most likely it's not osteo if we're not finding anything else, okay? So this is an interesting case study. This patient was in our wound clinic, initially treated for this wound on the hallux, okay? So he's being treated, doing okay. And then we started to get this wound on the second toe. Well, he came in and he had been cutting off his own bandage, which we tell him not to do. In this case, we didn't want him changing his own dressings. We were changing his dressings. But he decided he didn't want his dressing on for that day for whatever. So he got scissors and started cutting it off himself and cut his second toe. Okay, well, now we got 2 wounds to deal with, but whatever, he comes in, okay? So 2 weeks later, he comes back in, and we're getting baseline radiographs, making sure everything is okay. Actually, more looking at the hallux than anything. But there's this wound, and this is an image from we have this capture system, and it measures the wounds for us, and that's why you're seeing those blue dots there. But that's the wound on that second toe. It's a little bit erythematous. We're starting to get more concerned about the second toe than the first toe, okay? So we take the x-rays. What are we seeing on x-ray? Do we see any osteo there? People saying yes, people saying no. Okay, no answers, that's what I'm getting. Okay, there's some deformity. There's angular deformity on that second toe, right? This toe has kind of always been that way. The answer is there's no cortical erosions right here, okay? The x-ray is normal. So he comes into clinic, he's got a wound. It's a little bit red, it's a little bit infected. X-rays are normal, okay? Lab findings aren't, we do all this stuff, it doesn't look like osteo, okay? 10 days later. What's wrong now? There's changes, right? There's significant cortical erosion changes on that second, right where that wound is. It's bigger, it's macerated, there's a little bit of purulent drainage. He's running a fever now, okay? So Yeah, he lost his toe, okay? So something very innocent, essentially 3 weeks later, he had lost his toe, okay? So did he probably have some infections, some osteo at this point? Probably, okay? He probably did. It's probably one of those cases that it didn't show up for a while, showing how much it changed over the 10-day period. But at this point, at this point, there wasn't anything that was really telling us osteo, so it wasn't, let's cut off your toe now. It was continue to do the good wound care, and then when it got worse, we had to amputate, okay? So putting all those together, putting all those information together. Okay. So yeah, there's just the comparison. So we can go back to our baseline. The baseline's on the right side. The osteo is on that left side of just showing that cortical destruction, okay? I don't need to get an MRI on this. I don't need to get a bone biopsy on this. I didn't do a deep wound culture on this, right? He got his toe cut off. It's all in, I can see when I go into surgery, what's healthy bone, what's unhealthy bone. I take it off, and we're good to go, okay? So treatment, a lot of times it's amputation, okay? We're talking about antibiotics and stuff like that. 6 weeks of treatment is generally needed if you're gonna treat it with IV antibiotics instead of surgery. But a lot of times in the foot and ankle, you do it for 6 weeks, they get off of it, and it comes right back again. Rarely in a foot and ankle, especially in diabetics and people with peripheral arterial disease, does IV or oral antibiotics actually treat osteomyelitis. So, and I usually tell people that up front, like, we can try, but it's probably gonna come right back, and we see that most of the time. So amputation is definitely the best option. This paprika bone sign that you're seeing in this picture, that's just healthy bone. We're seeing a little bit of bleeding that we see intraoperatively, okay? So we can determine what's good, what's bad. So this was an interesting study about oral versus intravenous antibiotics for treatment of bone and joint infections. Those are the different meds. Conclusion, oral therapy was non-inferior to IV therapy when used for 6 weeks in a well-selected patients. So basically, they don't necessarily need oral IVs, or oral antibiotics if we're treating for osteo. We can use orals as long as we know what we're treating, what bug we're treating. So, which is pretty interesting. So, and it's a lot easier to treat with orals than IVs. This is looking at 6 versus 12 weeks of antibiotic therapy for osteo. 6 weeks is generally enough. We don't need to do more. We don't need to be doing 12 weeks. So sometimes you guys or the primary care providers, send us the patient because they have a wound, and then we start doing this dance, right? You've got the surgeon thinking one thing, and then infectious disease is like, I'm gonna do my thing, and then pathologists and radiologists, and it's just like this whole back and forth. Everybody wants something else, right? Differently. And in primary care, you're kind of sitting back there just watching the match, right? You're like, okay, you guys do your thing. I'll just sit here. And then sometimes this happens to the primary care provider watching, right there. Yeah. So just be careful, right? Yes. Yeah. We started some oral antibiotics that second visit, at that 2-week mark, to try to help it, and then we saw it 10 days later, and it just got worse. So, is this what we feel like sometimes with our feet, right? Okay. I'm almost running out of time here. I'll finish this up quick. Lab findings, Charcot, when we're trying to deal Charcot versus osteo, which can be hard sometimes, osteomyelitis is just going to be increased lab values. Radiology, sometimes it's very similar bone destruction, but Charcot is going to be multiple joints, and osteo is going to be more specific. It's going to be more where the wound is. We're going to get fragmentation in both. We're going to get more joint subluxation rather than joint erosion in Charcot. We see some periosteal reaction in both. MRI, almost similar. They're very, very similar in our MRI findings, so that's why it can be very difficult if you're trying to rule out Charcot versus osteomyelitis, which sometimes we have to do. Usually it's more rear foot calcaneal stuff that we're dealing with. So as we look at this, clinical, okay, so this is going to be the interactive portion. I'm not as interactive as last time. Positive clinical signs, so positive clinical signs, infection, stuff like that. No ulcer, negative x-ray changes, but positive MRI. What do we think, Charcot or osteo? What do we think? I can't hear anybody. Charcot? Charcot's a vote? Charcot. Okay, so that's our Charcot. What about positive clinical exam, positive ulcer, negative x-ray, negative probe to bone, but we have positive MRI? Charcot? Charcot it is. Man, you guys are good. Negative clinical exam, so no red, hot, swollen, no erythema or anything. Positive ulcer, positive x-ray, positive probe to bone, and positive MRI. Osteo, right? Okay. Positive clinical exam, positive ulcer, negative x-ray, positive probe to bone, positive focal MRI. Osteo, right? What about a positive clinical exam, a positive ulcer, positive x-ray, positive probe to bone, and a positive MRI and being diffuse? Both? Yeah, that could be possibly both, okay? Okay, so in review, we rarely need a bone biopsy for diagnosis of osteomyelitis, and I would argue an MRI as well. Antibiotics in general, and IV antibiotics are overutilized in diabetics, both in our Charcot population that have acute attacks and in diabetic wounds in general. We give way too many antibiotics when they're unnecessary. Charcot should be on a differential with an acute red hot swollen foot in a diabetic, and osteomyelitis is a team, not an individual sport. So lots of different tests, use lots of different tests to figure it out. So there's my references, and there's my kids. So in my introduction, they said I had 4 kids. You see 5 kids there. The one on the far left is our exchange student that we have from Spain this year. So she's our bonus this year. So anyways, any questions? Yes. Okay, so the question was, in our Charcot patients where surgical options aren't great, do people just ask for a lower limb amputation and just to be done with it, basically? You do see that sometimes. The risk we run with, there's lots of good studies that show once patients get a BKA, they have less than 5 years to live. Okay, and part of that is because they're so decompensated because they have so many other comorbidities. The extra stress that is put on their body without the leg just like puts them over the tipping point. So most of those patients, so once you get a BKA, you're gonna live less than 5 years. And that's pretty much all patients. So the patient may want it, but we also have to be cognizant of we're signing their death sentence in 5 years if we give them a BKA. So that's why sometimes that crow boot or that other thing is a better situation because it can hopefully prolong their life. So, but all considerations for different types of patients, right? I mean, if they're getting wounds over and over again and they've already lost multiple toes and they've already had amputations, yeah, maybe just a BKA to be done with it is the best scenario because they're already gonna have a short life anyways, unfortunately. Yes? Okay, the question is Charcot unilateral or bilateral for most patients? It's possibly both, but usually unilateral. It's usually unilateral. Yeah, so question is if it's unilateral and they get a crow boot, do you get something special for the other foot? These patients should be having custom diabetic shoe gear anyways, right? And if they get a crow boot, then they can build the custom shoe on the other side with a height elevation to match the crow boot. So yes, so they're just taller and they're not off kilter and stuff like that. So yes. Other questions? So the question is, with the BKA survival rate being poor, is that any BKA? And the answer is no. So it was pretty interesting when I did my residency at Madigan Army Medical Center. You know, we had a lot of very healthy people, IED blast, major foot and ankle trauma, and I did a BKA on a 23-year-old guy that was otherwise healthy because he just didn't want to deal with chronic opioid use and multiple reconstructions and an abnormal foot. And those patients, like those specific patients that have BKAs, do really well because they're not decompensated. Okay, they can get back and they can get great prosthesis, and they don't have those other comorbidities that are already dragging them down. So in that subset of patients, or those patients that have a traumatic amputation, no, those statistics aren't true. Yep. I saw other questions over here. Okay, the question was on the early Charcot radiographs, there's a lot of claw toe deformities and stuff like that. Is that an early sign? Not necessarily. Sometimes you're going to get that, like in cavus patients and patients that are have a really high arch foot and stuff like that, you get a lot of those claw toes and stuff like that. In degenerative neurological disorders, you also get those as well, but not necessarily in Charcot. So. Okay, so the question was, in the surgery patient we looked at with the Charcot that just was a failure, was he compliant or non-compliant during the surgery? Like throughout, he was, I would say, one of my more compliant patients, right? He was pretty good about the X-fix and everything, and it just, we have to understand that, not only are some of these patients, non-compliant to start with, but their bone structure is not normal, right? The way their bones heal and break down, and there's lots of abnormality. They're not going to heal normally. They're going to produce too much bone in some places, or not enough, or they're not going to have that construct that they need. So a lot of it is more due to the underlying disease that's causing those complications, in addition to the non-compliance. So even in the best compliant patients, we still have failures because, and we don't know exactly, like with the research, we don't know exactly what causes it, so we don't know quite what's making that bone structure abnormal. Other questions? Okay. Well, thank you very much. So it was good to be here today.
All right, before we go on our afternoon break,